Tēnā koutou, tēnā koutou, tēnā koutou katoa. I'm going to start with a karakia to welcome everyone who has journeyed here tonight from around the motu and from our very different days, and to focus us all on tonight's conversation, joined together by our shared curiosity and willingness to learn. Tū taua mai I runga, tū taua mai I raro, tū taua mai I roto, tū taua mai I waho. Kia tau ai te Māori tū, te Māori ora ki te katoa. Homie, huie, tai kie. Ko Tara Satyanand tōku ingoa. Kei te Aparangi ahau te mahi. My name is Tara Satyanand and I'm Director of Engagement and Education at the Royal Society Te Aparangi. The Society is basically a huge network of researchers from around New Zealand. Our purpose is to build pathways for science and research to be shared for the benefit of all. So it's my job tonight to do the health and safety first of all. So in case of a major emergency, there are exits here, and that's a flat, accessible exit. There's another one there with stairs, and we'll follow Sahara, the venue manager, who will direct us to the assembly points, which are outside in the octagon. In case of a minor emergency, or to avoid one, please put your phone on silent now, and notice that the toilets and wharepaku are just through that door there. If you need them, the centre one is an accessible toilet. Please be aware that our speakers have given consent for this event to be recorded so that we can reach a wide audience. Before I welcome our speakers, I'd like to thank our hosts, the New Zealand International Science Festival, for the huge amount of work that's gone into organising the festival and all the events. It's been a wonderful meeting of minds so far, and I'll definitely be coming again next time. I'd also like to acknowledge our partners for tonight, Bridget Williams Books, the University of Otago, Whakaihu Waka, and Te Pūnaha Matatini, the Centre of Research Excellence for Complex Systems. Now I'd like to introduce our speakers. Note that I'm standing in front of everybody, so please forgive me. Epidemiologist Sir David Skegg, who will marshal the discussion tonight, is a public health expert who has led organisations like the University of Otago, the Royal Society, the Health Research Council and the Government Science Board. He's advised the World Health Organization and the International Science Council for many years, and during the pandemic he advised our government through its Epidemic Response Committee and its Strategic COVID-19 Public Health Advisory Group. Now we'll go in order. So next is Professor Shaun Hendy, a physicist and the author of the book which has inspired tonight's discussion. He's a member of the New Zealand Order of Merit and a Fellow of the Royal Society, and he and his team at Te Pūnaha Matatini won the Prime Minister's Science Prize for their role in forming New Zealand's response to the pandemic. He's also been awarded the Callaghan Prize for Science Communication and the Prime Minister's Prize for Science Communication. Immunologist Professor Dianne Sika-Paotonu is Deputy Vice-Chancellor at the University of Otago. Along with a Fulbright Scholarship, she's been awarded McDiarmid Young Scientist of the Year, the Cranwell Medal from the New Zealand Association of Scientists, the Prime Minister's Science Communication Prize, and the Callaghan Medal for Science Communication. She was also in the team that won the Health Research Council's Liley Medal for their work on rheumatic fever. Her expertise on infectious diseases meant that she became a trusted voice during the pandemic and saved many lives by convincing communities to be vaccinated against COVID-19. Last but not least, evolutionary biologist Professor Jemma Geoghegan has a chair in viral pathogenesis at the University of Otago. She's a Rutherford Discovery Fellow and has been awarded both the Prime Minister's Emerging Scientist Prize and the Prime Minister's Prize for Science Communication for her research on infectious disease and the use of metagenomics to trace the evolution of viruses. During the pandemic, she was at the forefront of integrating real-time genomic sequencing into our defences against COVID-19 and explaining that to the public. So, over to you, Professor Skegg.
Kia ora tātou. Thanks very much, Tara, and good evening. I think I should congratulate you all on being in the minority of New Zealanders who are not trying to forget all about COVID, including some of our politicians. It obviously was a very intense experience, although less so for us than most other countries, and it lasted a lot longer than most people expected. We were just saying before that you may remember that when Grant Robertson was the Minister of Finance, I think it was in March 2020, he said, I think COVID's going to be a short, sharp shock to the economy, but that certainly didn't turn out to be the case. But if we try and forget about COVID and don't learn from the experience and plan for the future, we may do a lot worse next time. So I should just start by commenting on the title for this session. It's called Life After COVID. But as you will know, COVID has not gone away. I just looked it up. In the last week, 21 people died with COVID, although only in 13 of those 21 was the death believed to be caused by COVID. And 3 of the people who died last week were in their 40s. In the latest week, in June also, there were 128 people admitted to hospital with COVID. And about half of those had passed their 70th birthday, like me, but there were actually 15 children under 10 admitted to hospital in that 1 week. 3 in their teens, 2 people in their 20s, 3 in their 30s, 8 in their 40s, 12 in their 50s, and 16 in their 60s. So that's just in 1 week. So this is not a forever gone problem, unfortunately. But although it is still a very significant problem, we're interpreting the title for this session as Life After the Acute Phase of the Pandemic. And we're going to focus particularly on the likely course of the COVID epidemic from here on, and also on the probability of future pandemics and how we should prepare for them and respond. And of course, we first have to learn from lessons from what we've just experienced, the strengths and the weaknesses of our response. And we're very fortunate to have on the panel Shaun Hendy, who's just written a book, a very personal account of the pandemic, a memoir really, and it's a very good read. Shaun has written from the perspective of a mathematical modeller, and other people might have written from a different perspective, but he's given a really good overview of the pandemic response in this country. One thing that really struck me reading this book, and I've already mentioned this to Shaun, is his memory for detail. COVID took over my life for about 3 years, but there's no way I could remember that I had a second cup of coffee on one morning before a particular interview. So I'm going to start by asking Shaun, did you keep a diary, or did you use poetic license just to make the book more readable?
I've been asked that question a lot, actually, and the honest answer is I didn't keep a diary. I had a notebook, which when I went back to it was pretty much useless. I had kept notes, but they weren't particularly useful when it came to writing the book. I do have some really, really strong memories of particular events,
yes,
and those are the things I think where I have written about in the book. So I have these quite strong memories. I mean, it did take some time to sort of reconstruct everything. Sometimes I'd be confused about the order in which certain things happened, and then I could go back. And of course these days, a lot of what happened is stored in your email.
yes.
So I spent a lot of time going through my emails. I had to OAA some of my emails because I'd accidentally deleted a few really crucial ones. I was like, for sure I had this email and I couldn't find it. But luckily, when you OAA the Department of Prime Minister and Cabinet, they get back to you quite quickly when it's your own emails. So there were things like that, and then I had to talk to a few friends. My wife, I knew she was always, if I made something up, she was going to be like, no, I don't think so, dear. And it's based around a sort of a set of quite strong memories of particular events.
Right. Well, what I'm going to ask you to do now, and it's a big ask, is if you could just sum up in a few minutes, really sort of how prepared New Zealand was for a threat like COVID, how we responded, and how the outcomes here compared with those in other countries.
Yeah, and that did take me about 8 chapters.
Yes, you've got 5 minutes.
Yes. I mean, look, I think we were prepared there or thereabouts. You know, I mean, we weren't completely caught off guard. There'd been a lot of work done over a couple of decades, including by people like yourself and some of the colleagues here, trying to think about what we might face and how we might respond. And there was a New Zealand pandemic plan that the Ministry of Health had developed. And then revised over a number of years. So we did have a plan. You know, on the other hand, we do have relatively weak health infrastructure, yes. Public health infrastructure. You've written about this yourself. And so in many ways we were behind the 8 ball compared to a lot of other countries. And then, like most countries, we were caught off guard by the nature of the pandemic. Yes. Our pandemic plan was based around an influenza pandemic, right? That's what we prepared for with particular characteristics. And we faced a different type of pandemic with the coronavirus. So we'd made some preparations. I think if you stacked us up internationally, we would have said, well, we're not absolutely the worst, but we're nowhere near the best. Having said that, look, we actually did really well. Compared to a lot of other countries. And that shows up in lots of different statistics, including around things like, although we know people are still dying of it in New Zealand, the health burden has been less than many countries overseas, and we can see that in the statistics. We had fewer restrictions on average than most other countries, certainly most other Western countries. And then economically we came out of it relatively strong, and so overall, our response was actually in the moment one of the best in the world.
No, thank you. I mean, you're right. Our health system was not well placed. If we had had the sort of, other countries like Italy and the UK, parts of the US got just completely overrun as well. But in terms of things like intensive care facilities, we were right near the bottom of the OECD, weren't we?
Yeah.
Still are.
No, absolutely. We didn't have the capacity to soak up many cases at all and deal with that in New Zealand. And so we had to respond quickly and swiftly. And we were lucky that we weren't among the first countries to be hit. I mean, it certainly could have been a possibility of cases coming from Wuhan to New Zealand very early on, but luckily that didn't happen, and so we had a bit of time.
Yes.
And I think we used that time reasonably well.
I think most New Zealanders realise that we avoided thousands of deaths, and we saw what happened in other countries on television. But I don't think most people realise that we also had fewer restrictions and spent less time in lockdown, because everyone thinks, oh, we suffered so much. But actually, and you bring this out in the book, that there's this thing called the Oxford Stringency Index, which is run by it's a group at Oxford University who study international data on all sorts of things. But one of the things they did wonderful work, I think, on COVID. And it's the best place to go to if you want to find out about different countries' excess mortality and so on. But they also have this thing called the Stringency Index, which is a measure of the restrictions that were on at different dates in each country. And one of the points that you make in the book, Shaun, is that New Zealand, we actually had a less restrictive time than Sweden, which was always being talked about, because Sweden didn't have lockdowns, but overall they had more restrictions. And I just wanted to, and of course they ended up with a lot more deaths than us. I wanted to ask you, could you explain the different economic effects of either having very rigorous lockdowns, as we did in New Zealand, because our ones were stricter than almost anywhere, compared with having more relaxed restrictions over a longer period?
Yeah, I mean, the key to sort of understanding this is think about how fast restrictions bring down cases. Yep. So, if you want to get rid of the virus, you want to bring that R number, right, the R naught
Yes.
number that I wrote about a lot in the book, which
Yep.
is you want to ensure that every case is passing it on to less than one other case on average.
Yep.
But to be as efficient as possible, you want to do that as quickly as possible. And so that's actually what we ended up doing.
Yes.
Because we had those very, very strict lockdowns, they were amongst the strictest lockdowns in the world. We actually brought down case numbers faster, and of course we were able to bring them to zero.
Yeah.
So now you look at Sweden, they never brought that R number down below 1 for a long period of time.
Yes.
So they spent 2.5 years with cases, while we were, we'd have these occasional lockdowns, and then periods of relatively normal activity, and very few other parts of the world had anything like normal, normal economic activity. And so if you do the numbers, it turns out that ours was cheaper than Sweden's.
Yes.
And you can see this not only in economic figures, but in things like lost days of schooling. So Swedish kids, their schools weren't closed, but their teachers were sick.
Right.
Their parents were sick, they were sick. And so actually a Swedish student lost more days of schooling than a New Zealand student because of those two approaches. And that was specific, it should be clear, that was very specific to COVID and the types of restrictions. That won't always be the case for future pandemics, but it's something that you need to think about going into a pandemic, which of those strategies are going to work well. And to be fair to the Swedes, it was as clear as mud early on as to how that was going to go. But as it turns out, in retrospect, ours was the least impactful strategy in terms of the economy and other parts of our lives.
So there may be a bit of luck in that, because you have to make these decisions in a day or two.
Yeah.
But I remember Grant Robertson, one of his quotes at the time that did turn out to be true, I think, or perhaps we can comment. He said it quite often. We think that the best health response will be the best economic response, which is, again, a lot of people imagine there's a trade-off, and you either do well with one or the other. But do you think, as it turned out, that was a reasonable
I think
to say?
that's the most. I mean, it's even with hindsight, it's difficult to be completely clear about that. But largely, I think the evidence points to that being true. Like I say, the elimination strategy won't always be the most economically. So that won't always be the case. But I think with COVID, where that call turned out to be right, and that shows up in the data retrospectively.
No, well, that's all good, and we'll come back to some of those things in a few minutes, Shaun. But now I want to just direct some questions to our other panellists, and then you will have an opportunity at the end. That's the sort of plan for this session. I'm going to go to Jemma first, because Jemma, a particular feature of the New Zealand response, which Shaun doesn't really go into any detail in the book, was the use of genome sequencing, and I think this was something where New Zealand really was a leader. I wonder if you could just explain what genome sequencing is and how that was used, in real time during our pandemic.
Yeah, so genomics really played this starring role not only in New Zealand but throughout the pandemic. And it's where we can reveal the genetic code of the virus, and then, which is made up of a bunch of letters, 30,000 to be exact, and then we can compare those letters from one person's infection to another person's infection. And so if they are more similar, then we can infer that those cases were related somehow. Perhaps they infected each other or were related in the same transmission chain. And so what we did in New Zealand was, during that first wave in early 2020, we were able to really rapidly build up capacity and capability to then reveal sort of how many times the virus was introduced before lockdown, how quickly the virus was stamped out through these transmission chains during those lockdowns, and really assess how well interventions sort of prevented new cases. And then, because we were in the fortunate position of having no cases in the community for quite a long time, we were able to then ramp up that capacity to then get to a place where a sample would be taken from a case, and within 6 hours we'd be able to reveal the genetic code of that virus, which meant that we could then use it in real time to inform how people were transmitting the virus to one another. And so, because we had about 18 months where we didn't really have much community transmission at all, but during that time we had over a dozen cases, over a dozen instances where the virus was leaked from the border into the community. Sometimes it would just be a couple of cases, sometimes it would result in another Auckland lockdown. And so every time during those, it was about 15 times that happened, we would be able to produce genomic sequencing of those viruses and either link cases directly to the border, which meant either a case in the managed isolation and quarantine hotels or a border worker or someone at a port. And if we knew they were linked to the border, it would give some satisfaction of decision makers that this was a very recent leak. And we would only have to perhaps lock down a region rather than the whole country. If it wasn't a known source, then that would we would infer that potentially there had been cryptic transmission in the community for some time, and perhaps that would result in a more stringent lockdown. So this is the ways that New Zealand was in using genomics. And what we kind of showed to the world is how we could do it so rapidly and so intrinsically by sort of marrying it with all the epidemiological data, because we knew everyone's travel history. So when people were coming into these managed hotels at the border, we knew where they would come from, where they were seated on that plane, which room they were in, and of course they weren't allowed outside of their rooms. So when there was transmission on flights, for example, or within MIQ in these hotels, we could track and trace how these events happened. And through that, we could actually say that people could transmit the virus without being in the same place at the same time through aerosol particles. And that's kind of one of the major pieces of evidence that changed the WHO's mind about use of face masks, for example.
Thank you. That's great. Dianne, you're an immunologist, and one thing we haven't talked about yet are vaccines, which were a key part of, obviously, the getting a hold over this pandemic. Before I get on to other things, do you want to say anything about, how vaccines were developed in this particular epidemic? And I think you'd probably say that it was unusually quick that we were able to get effective vaccines produced, not as quickly as we would like, but would you like to comment on that, the role vaccines have played?
Sure, and thank you so much for the question, also for the invitation to join you all this evening. So yes, certainly the first COVID-19 vaccines were developed very, very quickly, and were done so as a result of a lot of barriers that would normally be there that would prolong the process. So when you're looking at normal vaccine development, you're looking at least about 10 or so years with a number of very rigorous steps that take a lot of time to be completed and to be done carefully and properly. What happened with COVID-19, on the other hand, was that with this sense of this very strong sense of urgency and panic, likely that a lot of barriers that might normally have been there were no longer there. So, for example, money all of a sudden wasn't a problem. Global collaborations between scientists who might not normally be sharing information with each other, what was taking place. There was a lot of interest and a lot of goodwill and a lot of investment that was there in ensuring that we did have a vaccine available as soon as possible. There were so many unknowns, particularly at the start of the outbreak, that it was a pretty scary time for everybody. So yes, those first COVID-19 vaccines were developed very, very quickly. There were also a lot of people volunteering as well for clinical trials in a way that might not normally have occurred. So that global widespread collaboration, the the goodwill, the investment, the funding, all these things just happened really, really quickly, and that's not normal for us as scientists. It usually takes a long time, a lot of energy to get money to do research and to develop new medicines, etc. So it was a pretty remarkable feat to have the vaccines ready so quickly.
Thank you. Now, the other thing I want to ask you about your new position down at Dunedin here is as Deputy Vice-Chancellor Pacific at the University of Otago. And I know you have a particular interest in Pacific health, and I'm going to ask you about Maori health as well. I think it's very sobering. I just looked at the data again today, that if you look at the number of deaths that have occurred from COVID-19, where COVID-19 was certified as the main cause, for people under 60, this is over the whole pandemic here in New Zealand, the number of deaths among Maori and Pacific people, the absolute number, is substantially higher than in the rest of the population combined, which is really remarkable when you think of the relative size of the populations, and also that even in that under 60 age group, the Maori and Pacific populations are at a much younger age structure. So if you adjust it for age, there are actually more deaths in those two communities than in all the rest of the New Zealand population. Now, there are a whole range of factors involved here, I know, but what do you think are the main reasons why Pacific and Maori people have been so badly affected during this pandemic?
Yeah, again, thank you for the question. So NZISF signalled there are a whole host of reasons as to why Māori and also Pacific are disproportionately impacted and affected by COVID in different ways, in terms of the deaths, the hospitalisations, but also the severe illnesses that result. And if I just might add that at the start of the pandemic, towards the beginning of the onset, where we were here in Aotearoa New Zealand, we were watching what was happening in other parts of the world, and there were some really scary statistics that were starting to come out of the US, highlighting highlighting the added risk for Indigenous peoples.
Yes.
There are a lot of Pacific peoples who live in the
Yes.
US, and the death rates were just the highest and pretty scarily high. And it was work here in Aotearoa New Zealand undertaken by Shaun's team and also by Michael Baker's team that signalled that we were likely to see very, very high, a disproportionate impact of COVID on Māori and also Pacific communities. So some of the reasons include pre-existing health issues, and as a member of the Pacific community, I can attest to the fact that we have lots of health challenges. And again, at the start of the pandemic, some of the risk factors for ending up with severe COVID weren't so obvious. So these were things that we discovered as the pandemic developed. Other reasons include things like intergenerational living. So in our communities, it's quite common for lots of members of the family all to be living under one roof, and lots of cultures do this, and that inherently is not a bad situation. However, the issue was a highly infectious virus that could get in and spread very quickly in communal settings. So other issues include things like the socioeconomic status in some instances, accessibility to healthcare, which can be problematic for a lot of people, but we know that in our Pacific and in Māori communities that sometimes people don't always get the help that they need at the time that they need it. So accessibility to healthcare is a major issue for our peoples, and there are others, and I could talk at length, but those are some of the...
No, that's really great, thank you. And of course we've seen it with past epidemics, and even going right back to the influenza pandemic after the First World War. Maori people suffered particularly during that period, so it was predictable and it was predicted, and yet we still didn't avoid it. And one thing that I would like to ask about is the vaccination rollout. Now, I know that the government did think about having a rather more varied program, that they decided to stick with sort of one program. But later they changed that, didn't they, and realised that the vaccination uptake in Maori and Pacific people was not as high, even though it needed to be higher because of their increased risk. So would you like to comment at all on why that shift occurred and whether it was effective in improving things by taking a different approach?
Yes, I could say a number of things, but maybe just a few. Sadly, the Delta variant got in at a time when our vaccination levels were still quite low, and of course we know that that swept right through some of our Pacifica communities and Māori communities as well. So with respect to the one-size-fits-all model, and doing the same thing for everyone, anticipating that we'll get great outcomes for everyone, I mean, that approaching the vaccination rollout in that way was going to work for a lot of people, but not for everybody. And so for our Pacifica and our Māori communities, things had to be done a bit differently, and what actually was needed was more of an equity focus to the vaccination rollout, i.e. taking into account the respective needs of different groups and communities. So in other words, not doing the same thing for everyone, but some of the things that were done, for example, were instead of making people come to get vaccinated, vaccines were taken out to communities. Instead of making people come to get healthcare at a centre or a clinic, healthcare was taken to people. So this sort of helped overcome some of those barriers. Some of the big barriers in terms of accessing not just healthcare but vaccines can be transport, inflexibility around appointment times, also cost as well. So by reducing those barriers and taking those into account with the vaccination rollout, that was able to help there. Also ensuring that there were more targeted and tailored approaches to reaching and connecting with communities. For example, in our Pacific settings, a lot of our Pacific community leaders, a lot of our Pacific scientific leaders, a lot of our Pacific clinical leaders got on board and were helping with the rollout. And when things like that started to happen, also akin to what was happening for Māori, that's when vaccination levels really started to go up. So I hope that's helpful.
Yeah, no, that's great. Thank you, Dianne. Now, I'm sure we'll come back to some of these issues at the end, but I'd like to move on now to the road ahead, which was the other part of the prescription for this session. And as Tara mentioned, I was involved with a group convened by the International Science Council looking at the future of the pandemic. And one of the conclusions in this project was that the social and economic effects of the pandemic will be even more long-lasting and profound than the health effects. And there's a very big report on the International Science Council website if you're interested about this. But COVID has changed so much in societies all over the world. And problems like misinformation and disinformation, which were around anyway, and of course with the rise of social media, were increasing, but the COVID pandemic just supercharged that. We might come back to that later. Loss of trust in science and government, because governments were having to do restrictive things. They all said they were following the science. The point you make, Shaun, we said New Zealand followed, but Boris Johnson said he was following the science, and so did Trump. That's why he knew that chloroquine and ivermectin were going to be the solution. So there's been a breakdown in trust, which is going to be hard to repair. And then there's the long-term effects of disrupted education. And as Shaun said, fortunately our kids had less disruptive schooling than most countries, but in some countries they had very long periods. And there's been a big increase in mental health problems in young people in their 20s, which again was actually, you can show, was developing before the pandemic, but it didn't help. I just feel so sorry for people who went off to university, then they had to sort of work from their room, might as well be at home. So many of these impacts, and also there are big economic effects, particularly on developing countries, and these are going to reverberate, for years ahead. But we're not social scientists, so I'm just raising those points, but really saying that we're going to focus mainly on the medical and public health aspects. But there could be a case for a whole another seminar with a number of social scientists here to talk about those really important issues. But I'm going to start by going back to Jemma Geoghegan, because she's an evolutionary virologist. I think, Jemma?
That's right.
And I'm going to first ask you about the likely trajectory of the COVID epidemic. Because we've all watched the emergence of new variants. We started off with the Wuhan virus, then we had Alpha, Delta, Omicron, and so on. And as I understand it, Jemma, new mutations are occurring all the time, but for them to get established, they need to be more transmissible than the variants that are prevalent in the population. But of course, a new variant could be either more or less lethal than the ones that are there. And we've been very lucky that Omicron is less lethal than Delta was. And when Delta was going on, and I think people who sort of pontificate about the pandemic often forget that when we're in the midst of Delta, we didn't know whether the next variant was going to be more or less dangerous. And it's easy with the wisdom of hindsight to say, oh, we could have done this earlier or a few weeks earlier, but we didn't know what was coming next. But what I wanted to ask you is, we must have had sort of sub-variants of Omicron now for about 2.5 years. Do you think that this virus has reached the end of its evolutionary potential? Or could we end up with a new variant that's more lethal, much more lethal? Is that still a possibility? Or is it likely we'll now just continue having sub-variants of Omicron?
Yeah, so I think that we will never reach its evolutionary end, if you like, because there's never an end game for viruses.
Yeah.
Basically, there's this sort of constant battle between the host, which is us, and the virus, where the virus needs to try and infect us, and our immune system is trying to stop it infecting us. And both can change to overcome each other, but it's a constant evolutionary arms race, and there's never really a winner. But the virus will continue to surprise us, no doubt. At the moment, we're in sublineages or subclades of Omicron, and it's all one big Omicron cloud and then there's waves of dominant subvariants that come and go. And these are sort of waves that are very sort of reminiscent of influenza virus, for example. There's because there's lots of people that have been infected, and there's lots of people that have had vaccinations and boosters and so on. We all have a lot of immunity to it now. There's not very many susceptible people, and so the virus is constantly changing to find different ways of infecting us, and it will continue to do that. I think the future looks probably a bit more like our other respiratory diseases, such as influenza virus and RSV and things like that, where it will become more seasonable. So it'll become more predictable in terms of when instances rise and so on, because this is usually what happens in temperate climates, where we have more cases in winter and fewer in the summer. We're not there yet, but I think it's likely to happen. And we'll continue with this sort of Omicron sub-variants and sub-subvariants. However, there is a possibility where we do have a sort of a leap to a new variant, a new Greek letter maybe. I think the only way that could perhaps occur is if through sort of genetic switching of this virus with the virus that's hosted by a range of different animal hosts as well. Because we know this virus jumped from an animal, but it has also jumped back again many times to many different animals, and we know that cats and dogs and rodents and deer and all sorts of animals, lots of mammals, can be infected by the virus that we got. It is now jumped back to animals. It's likely spreading among them. There's not really surveillance of them. And so to get to another Greek letter, and this is what happens a lot with influenza viruses, for example, there could be another spillover event, recombination, which means that they switch genetic components a little bit so that it makes a brand new kind of variant that a lot of people are susceptible to. And by chance, it's really good at infecting people, and then it takes off, and it could potentially be more severe. The severity of disease is really hard to predict because the virus only really cares about infecting the next host, no matter what type of disease it causes. So it's always, there's this sort of fallacy thinking that viruses are always going to attenuate to become less severe. It's partly true, but not intrinsically of the virus. It's only true because we have more immunity to cope with the infection better. So a new variant that our previous, infections and our previous vaccinations can't recognise, then it could potentially be more severe.
Yeah, it's a very common misconception,
Yes.
isn't it? Even among health professionals.
Yeah.
Oh, every virus is going to become less, but it doesn't. It could go either way.
That's right. I mean, if smallpox, for example, was eradicated, and perhaps some of you were vaccinated against smallpox, but I'm too young for that. So, and if smallpox were to come back, it would be just as lethal as it was. And we know that smallpox has been around for centuries. So there's really good evidence to suggest that that's not true. That viruses don't always become avirulent.
And the smallpox virus is still stored in Moscow and Atlanta.
Yes.
So we hope it doesn't come back again. You made a very important point about the animals, because I remember that was one of the reasons we realised early on that this virus couldn't be eradicated. New Zealand was one of the few countries that was successful with elimination, which doesn't mean zero, but it means getting it down to a level where outbreaks can be stamped out. But smallpox has been eradicated, one of the very few. But we realised that wasn't going to be possible with COVID because people's cats and dogs were getting it.
Yeah.
And so there's no way you could eradicate it once into animal reservoirs. That's great, thank you, Gemma. Now I've got another question for you before I go back to the other panellists about where we go from here. And that is, we've talked a lot about COVID-19, but how likely is it that we're going to have to face a completely new pandemic in the next few years, caused by a completely different microorganism?
I think it's quite likely. I'm sorry to say. The reason why I think it's quite likely is, we've had a few pandemics since COVID. Didn't hugely affect us. We've had Mpox, for example, and other viruses that have caused pandemics because they've spread widely enough. Avian influenza virus, or bird flu, is something you've probably all heard about. The reason why you've probably heard about it more recently is because at the same time as COVID was happening, in about 2020, a new lineage or a new variant of highly pathogenic bird flu emerged in Asia, but it's since, over this past sort of 4 to 5 years, this lineage, this subvariant, is being responsible for millions of bird deaths. It is continually spilled over to mammals, especially marine mammals, killing thousands of marine mammals. It is now spread from poultry into dairy cattle, and it is endemically spreading in dairy cattle now. So every state across the US has reported positive cases in dairy cattle. There has now been reported cases in pigs, which is really, really concerning, because pigs are a bit like us in their respiratory system, so any virus that gets into pigs is quite worrying for the potential for a human pandemic. And there's been more and more cases for humans being infected without direct exposure to infected animals. at the moment, it doesn't look like this virus can spread between humans, but I don't think we're too far away from it being able to do that. Pigs are one of the reasons why it will be able to potentially acquire the ability to spread between humans. So I think the next pandemic, although I hate to predict the next pandemic, but I would put my money on a new flu pandemic.
And one of the things that has changed in the last few decades is the amount of movement of populations of humans, isn't it? If you compare with 100 years ago, that with air travel, that any virus that's got the potential to become a pandemic is likely to do so pretty quickly. So I'll come back now to Shaun and Dianne. What do we need to do about this? I think there's a consensus among scientists that there will be another pandemic as bad as COVID. It might be next year, it might be 10 years away. But what should New Zealand be doing now to make sure that we learn from the mistakes that were made with COVID, but also to prepare for other possibilities? So, Shaun, do you want to kick off? Because you do address this in the book.
Sure, yeah. I mean, one thing we need to be doing is reflecting on our experiences from COVID. There was an enormous amount of science done in that period. It's staggering the amount of science that's actually done around it. We've learned an awful lot, including thanks to some of the work that you guys did around aerosol transmission and the importance of that and the spread of respiratory diseases. So we know a lot more, and we should be leveraging that. And I worry about in New Zealand that we've just we want to put it behind us, which is completely understandable.
Yeah.
But because of these ongoing risks, we really can't afford to. We're not necessarily going to have decades to prepare for the next pandemic. So we should be thinking about it. And I know we do have the second phase of the Royal Commission taking place. But look, the Australians have already, they've moved from their commission into action. Yeah. So you can just look across the Tasman to see an enormous amount of work going on over there to prepare for the next one. And that's just not happening here. Dianne, you talked about the importance of collaboration and funding, and now is when we need that.
Yes.
We need some funding to start leveraging what's happening in Australia. I think one of the things that at least in the near term is going to be very different is the role that the US plays, and they were incredibly important in supporting the science, particularly around the vaccine development. It's not clear with the Trump administration that the US is going to take a lead in that way. And so for us, sort of sitting here, who benefited a lot from the work done in the US, we need to start looking for other partners. And Australia is an obvious partner. They're investing now, so I think we should be doing the same.
No, thank you. You mentioned the Royal Commission. The Royal Commission, the one that was appointed, actually reported, as most people probably know, at the end of November last year. One thing that really struck me was it got some news coverage for about 12 hours. Basically, people quickly looked for anything critical of what the government had done. That was newsworthy. But it's a very long report. I can claim, I might be one of the few people in New Zealand who's read the whole Royal Commission report, because it's over 750 pages long. And I actually read it because I got interviewed by the second phase, and I thought I better read right through. But it's got a lot of really good advice there. And it's got a lot of specific recommendations that New Zealand needs to do urgently, like appointing a minister to oversee, one minister who would oversee all the different parts of government that should be playing a role when a pandemic is on the horizon. But at the moment we're sort of treading water, so I hope that the second phase does complete according to its timetable, and then things get moving, because it would be tragic if we just are caught unprepared, as everyone was really with COVID.
Yeah, and I think particularly with the Australians doing so much right now, we want to be in with them.
Yes.
As our sort of closest regional partner scientifically. It's a wasted opportunity for us not to be working and taking steps alongside them.
Yeah. And also, one thing that we might be able to work with them, I understand, is in vaccine production, because that was one of the big issues with the COVID pandemic, was getting access to the vaccines. And you may remember that the Prime Minister actually had to ring up some of her friends, you know, who were presidents and so on, in one or two other countries, and say, have you got any spare COVID vaccines? Some of them had, because of course they've all got a time limit on them, and they bought more than they needed. So New Zealand actually was able to get some vaccine from other countries. I think Spain was one of them, and maybe Denmark. So that's always going to be an issue with a new epidemic. And in the future, it may be that New Zealand and Australia should be actually producing our own vaccines. In fact, the Australians did start doing that, I think, with the Oxford AstraZeneca one. But yeah, I just hope that we're going to get moving on this. And perhaps, Dianne, have you got any comment about, you know, particular aspects you think need attention now to prepare ourselves better?
Yeah, well, just building on what's already been shared, there were 39 recommendations as part of the World Commission report that would really help set us up. And I believe that there are some actions that have really sort of started happening, but that moving forward, that would be great to get more movement on what's already been signalled is going to be important for the New Zealand context. I just want to draw attention to something that the International Science Council released back in 2022, and I think you might have been involved in this, David, where there was a report that was shared looking at how globally we could be more prepared for another pandemic, and there were a number of recommendations in the particular part of the report I'm thinking of had 7 parts to it, but there were a couple that really they were all important, but there were a couple that really stood out to me, and the first one was addressing inequities. So if we're wanting to be better prepared for another pandemic, fixing gaps that we have right now with respect to health is a really important place to start. And of course, as a member of the Pacific community and working also alongside colleagues with Māori communities as well, was thinking about the health challenges that we know about already and that we are trying to address here in Aotearoa New Zealand, and that actually doing that work is also going to be really important for setting us up to be better prepared, because essentially what the pandemic did was exacerbate some of the pre-existing gaps that we already had here in Aotearoa New Zealand. So COVID just basically made a lot of things worse, but for us it made things much, much worse health-wise. And so moving forward, that was, I mean, there's more that I could say, but I think that's
a really good
what
point.
I'd like to leave with everyone.
And it's, you know, like so much in public health, it's a kind of reminder that no man is an island, you know, that some people take about it, I mean, countries took a very selfish view. You made the point, Shaun, that there was wonderful scientific collaboration, but in terms of the vaccine rollout, it was sort of sad, because I was on this international committee and everyone was saying, oh, we've really got to make sure that the vaccine goes to where it's needed most. But actually, each person's country then went back and, you know, sometimes bought 9 times more than they needed for every person in the country, while developing countries were having difficulty accessing any. And, you know, there was one person who kept saying, no one is safe until all are safe. And it was the same actually in the really sort of sadly prolonged Delta outbreak in Auckland, that a lot of the people affected were Maori and Pacific people. So it's no use sort of sitting in an affluent suburb and thinking, well, we don't need these lockdowns, but actually the whole thing was being carried on because of the people in South Auckland and so on who were disadvantaged. So yeah, we've really got to learn from that experience. Well, I think we can now open up. You've heard enough from us. I'm hoping that there'll be some questions for the panel from around the audience. So we haven't got a roving microphone, but the acoustics are pretty good here. So could I please just invite anyone to ask any questions? Yes.
I just wondered about the long COVID.
Yes, we haven't talked about it at all. This is a question for an immunologist, I think. Dianne.
Yeah, certainly long COVID remains a risk for people, not just here in Aotearoa New Zealand, but globally. And there are still some very high figures that signal that it is an ongoing problem for us. Perhaps more needs to be Zealand in order to be able to support those who have become very unwell and have become chronically unwell with the long COVID condition. But yes, it hasn't gone away, and it remains problematic for us, not just here in Aotearoa New Zealand, but globally as well.
Thank you. Yes. Yes, please.
Does New Zealand have a good idea of the people that did die and kind of the burden of disease that fell on different population groups and people geographically in New Zealand? Like, have you looked at the death stats?
Sorry, I couldn't hear that last part.
Have New Zealand looked at the death stats of the people that did die from COVID?
Oh yes, there's been a lot of analyses.
And see what they died from as well that were maybe linked health conditions to get that kind of burden of disease picture of the deaths of people rather than people that survived. I guess that you haven't really heard so much about the people that were dying. It was more about the virus rather than the people.
Yeah, well, no, there have been quite a lot of analyses of the mortality, not just by, obviously by age, but also by ethnicity, but also by the underlying health conditions. And that was one of the sort of marked features, really, that, and you touched on this, Dianne, that people with underlying health conditions did have a considerably higher risk of dying.
Is there being published research on that as a New Zealand perspective collectively?
Yeah, I'm not sure so much of it's been published.
Yeah, there is a quite, I mean it's dated now, but late 2022 or early 2023 report from Ministry of Health that actually gives a very comprehensive picture of exactly that.
Yeah.
I'm not sure if that's been updated.
Well, it is. You can still get the updated mortality data as of last week, on the web from the ministry. If you just put in COVID New Zealand mortality or deaths.
Although if you want to get into the
comorbidities, it doesn't go into
comorbidities. You need to go to that report.
Yeah,
and they stopped tracking it after it wasn't a political priority, or did they keep tracking it over that time?
No, and I think that there could have been a lot more analysis. Of course, it was all in a big rush, but I felt that, and the committee I chaired recommended there should be more studies of the people who did die to find out, did they get to hospital? If not, why not? Did they have Paxlovid? Because I think one area where we didn't do as well as we could have is that when antiviral drugs became available and they actually got here, the rules for who could get it were so restrictive. They were sort of sitting on the shelf, and people were getting very ill and dying. So everyone was focusing on prevention, which is obviously important, but you've got to think about treatment as well.
Yeah.
So I think that was an area where New Zealand didn't do as well as we could have, and I'm not sure that any other countries did better, but we should have been doing more to make sure that the people who got COVID got the best possible treatment. And obviously medication was only part of that, but I got particularly agitated. It was in the middle of 2022 that Pharmac had these rules, and then we wrote to them and said, I think you had to have 3 risk factors, in addition to age, and they said, oh no, that's not the case, it's been changed, but it was still there on the website. So doctors weren't prescribing it when they could have. So that's the kind of thing that I think could be done better next time. Yes.
Shaun, you mentioned that the empirical evidence around health outcomes and economic outcomes suggested, or shows New Zealand performed incredibly well versus the alternative strategies such as Sweden. But people's sort of mental experience or social licence is a different thing. And we saw the camp out in Parliament and the rise, as Professor Skegg said, of social misinformation and that sort of thing. Did you get an insight in that comparison between how the public, the society generally has fared in terms of their acceptance of the future in the next 5 or 10 years, if we have to go through this political upheaval again, whether we are going to be still in that camp of saying short and fast, or whether it will be a sorry no?
Yeah, I mean, the Royal Commission report reflects on this quite a bit, and I think this came out in the Australian inquiry as well, that we do have to do a better job of justifying measures next time. Now, I think the only way we'll do that is by being better prepared, because you do have a very short, when a new virus appears and you're trying to figure out what's the best strategy to handle this virus, you've got a very short period of time in which to make these decisions. And if you haven't prepared, if you don't have the evidence and thinking, partly on the shelf, you're always going to struggle to explain it to people. And even, just in the scientific community, right, we were struggling as well with should we call this elimination yet? Or, it says in the plan we've got, we're stamping it out. So the more we've prepared, the more scenarios we've considered, I think the better off we'll be when another pandemic comes along, in terms of being able to explain, what we're doing, why we're doing it, and why we think this is the best strategy for this particular virus. Because it won't look the same. I mean, you do tailor strategies for particular viruses. It won't be exactly the same as it was with COVID. Even a new variant of COVID, we'd be looking to do different things. So, the more prepared we are, I think the better position we'll be in to get that social license.
It's back there.
There's been one person
Sorry,
here, David.
I've come. Just the trouble with
go
my
for it.
chair facing this way. Yeah. Please go ahead.
Thank you. You've highlighted very well how we've learned a lot from COVID and how there's been lots of recommendations made about how we can prepare ourselves better in the future. What do you feel will be the biggest challenges holding us back from implementing that knowledge and implementing, like we made the recommendation, what's holding us back now from putting them into action,
I think political will, which in part comes from us as voters. If we're not asking our politicians to do things, they're not going to do it off their own bat. They're going to focus on the things that we tell them we want to focus on. And so I do think that as a country, it really is up to us. And if as voters we tell our politicians that this is important, we want to be well prepared for the next pandemic, then they will take action. They'll take notice of that. One of the things I really liked about the Royal Commission's report is that little appendix where they talk about, they start talking about pandemics in terms of return times, in terms of the way we think about earthquakes. And I think as a country, we grapple with earthquakes relatively well. Right? We all have a sense of that it's not when, it's not if but when, and it's the same thing with a pandemic. And so if we can develop the same sort of way of talking about pandemics and thinking about infectious disease that way, then I think that will start meaning that we as voters can ask for the country to be better prepared. So I think it really is up to us, and that's partly one of the reasons I wanted to write the book, was to sort of keep that conversation going before we forget.
Fair enough. Have I missed anyone else on this side? Yes.
So, Shaun, you talked a lot about you mentioned the rapid development in science that happened when scientists are properly funded, and there was that focus. And I guess I'm wondering, Jemma, you spoke about the rapid advancement in the genomic sequencing, say, during a period where we had a temporarily limited COVID. So, any of you comment on the science that took place, the development, the knowledge, the advancements, how it may have been applied to areas outside of COVID?
Maybe.
I mean, sequencing virus genomes is not a new thing. We've been doing it retrospectively to understand past outbreaks for a long time. What was new about this was that we managed to do it in real time, and that was new everywhere, and they were using it in that sort of rapid way. I think we were able to rapidly build up capability and capacity, but a lot of it was luck as well. The right people seemed to be around in New Zealand at the right time. We could easily lose that capability if it's not maintained, and so people have short memories, and if the capability isn't maintained and well maybe next time that won't be there.
Dianne, do you have any comment on that?
I was actually just wanting to comment on something
Yeah, sure, go ahead.
else from the book that you just reminded me of, if that was okay. And it was just reflecting on a number of memories that sort of came back to me as I was looking through. And one of the things that there were a number of things that came to mind, but one of them in particular was around how scary it was. And just reading through some of the specifics in Shaun's book was a really vivid reminder about how scary it was for everybody, and thinking about how life was going to change, the uncertainty, so much was unknown. What did this new way of life mean for work, for research, for families, for us as people in our place in society? And so it was something that came to mind, and also just in terms of how the experience that we had with COVID here in Aotearoa New Zealand was actually quite different to the experiences of many people who were in other countries overseas. And just thinking about for those who were in China at the early stages of the pandemic, northern Italy and the US, and it was something that I was reminded of after just coming back from some travels where people would hear my accent and ask, "Oh, where do you come from?" And I'd just say New Zealand, and nearly every person who I told who came from New Zealand would mention something about COVID and the pandemic and how they knew about our response and that they wished they had been here and not where it was they were. And so again, just a very helpful reminder about some of the things. A lot has happened over a very short space of time, and just reading through your book, Shaun, was reminded about some of these things.
I think it's an important point, a very good point that Jacket made about social cohesion. I remember reading in a book a medical historian wrote before COVID that a pandemic is like an earthquake or a flood, and it's a test of the cohesion of the society, how it responds. And I think New Zealanders respond incredibly well to things like floods. We're seeing sadly Nelson Marbury. They tend to be very helpful to each other. I think we're very proud of that. And the same thing was true of COVID, but then it all got sort of frazzled, didn't it, around that time of that parliamentary sit-in. And I think a lot of that was related to compulsory measures like vaccine mandates and passes and so on. But the real test will be when the next one comes. I'm pretty optimistic that New Zealanders will respond in a supportive way. And a lot will depend on the point that you just made about the fear that we all felt with this new threat, to our own families and our own communities. And we saw it on television. And one of our alumni from the medical school here, who's a distinguished doctor in New York, said to me on the phone, "I never expected, working in New York, because he works at the top hospital in the world in his field, I never expected to see nurses wearing disposable rubbish bags as PPE and ambulances in the car park used as morgues." And we just didn't have that. And we saw similar things in Italy where so many doctors and dentists were dying. And in India we saw those funeral pyres. So I think that concentrates the mind if it happens, but let's hope it doesn't happen. Now there was, yes, there's a person with the arm raised.
Thank you, Dianne. You mentioned the speed with which the vaccine was developed, and I think that was one of the main things of distrust was the mRNA. There was pushback, certainly in the parliamentary sit-in, that was a big thing that was related to the mandates. If mRNA is the vehicle of choice going forward with vaccines, is there anything within, for instance, the Commission report that might help us get over that major hump in terms of public trust, scientific belief going forward?
Actually, yes, there were quite extensive recommendations in the report with respect to setting us up as a country to be able to respond more efficiently, more flexibly, but also to have a lot of the groundwork done beforehand and to be set up in a way that perhaps maybe we might not have been set up for when COVID hit us for the first time. So that was the first point to your question. The second point I just wanted to quickly make was that with respect to the rapidity, the speed at which the COVID vaccines were developed, that this was something that worried a lot of people, and perhaps maybe what wasn't so well known or understood was that even though the vaccines were developed quickly, if anything, there were way more eyes. There was a lot more focus on the safety, the efficacy, etc. on these vaccines than perhaps maybe there had been. So, but perhaps maybe people
didn't know that. So maybe that's a thing that needs to be got up.
Yes, communications.
Yeah,
really
comms are
crucial.
Yeah.
There was a question in the back, I'm sorry, I moved over here and I missed you. Yes, please.
All right, first of all, I want to thank the panel for a wonderfully informative session so far, at least, and more to come, I'm sure. My question is sort of a desperate attempt to find a silver lining in the COVID cloud. And we know that, I think we know that during lockdown and lots of mass wearing and so forth, the incidence of other health conditions may have gone down because there's less transmission and less community engagement. In some very limited reading I've done, I've also read that it might be a thing that some vaccines against certain disorders might also offer protection against other infectious diseases that they weren't necessarily designed for. So my question is, is there any improvement in health statistics for certain disorders in New Zealand now as a result of having a more vaccinated population against COVID that might have actually offered some other advantage against other disorders? And or maybe just that people are more accepting of other people wearing masks and that sort of thing, whether there's been any improvement in any other statistics in the system.
Yeah.
So that's my question.
Thank you. There's two aspects, I think, to the point you raised. First of all, it's certainly true that because of the precautions that were taken during the pandemic, New Zealand's excess mortality actually went down. So we were almost the only country in the world that some countries, their life expectancy went down because there were so many deaths. Whereas in New Zealand, it wasn't just that we were avoiding so many COVID deaths, but also fewer deaths from other things like influenza. If you ask yourself, how many colds have you had in the last 2 or 3 years compared with the 5 years before that? I don't think I'm unusual, but I've had a lot fewer. Now, colds don't normally kill people, but we had less influenza, less RSV, and so on. So that's, and I think people are now starting to take more attention to things like ventilation of workplaces, not going to school or to work, especially work or church when you're sick. Sadly, some of the super spreader events were church services, and now most churches have on their website, please don't come if you're feeling ill. Whereas before, we all had this feeling, well, you just soldier on. So that's all positive. But your other question, has the vaccination against COVID affected other diseases? I'd have to ask Dianne and Jemma. So I'm not aware of any evidence that that's the case.
I'm not aware either.
No, I'm not aware of any evidence that that's the case. However, New Zealand's eliminated influenza, like you said, for 2 years, and it came back in 2022. We eliminated RSV for 1.5 years, and then during the travel bubble with Australia, it came back, and it was 5 times more cases, 6 times more hospitalizations. So actually, sure, we were healthy for a while because we had no one coming into the country and we eliminated everything. But when it came back with a vengeance. So we don't really want to eliminate endemic things because when they come back, people were under 2 and no maternal antibodies, and people under 2 had never been exposed to it before.
Thank you. Now it's time for one more question, I think.
I've actually got a comment about that last one, that if you go through the monthly respiratory disease reports for New Zealand and look at the area under the curve over time, the elimination period, things that have come back generally aren't as worse if you take into account all of the cases that didn't happen in the gap. And that particularly shows up in things like the recurrent pertussis epidemic that's nowhere near as bad as Australia as a reintroduction.
So first I'd like to thank you, Shaun, for writing this book, which has inspired tonight's discussion. As a scientist, you really stepped up and did your best to interpret the data for all of New Zealanders, but also for our decision makers who had to make those big calls. So we all owe a debt of gratitude to you and to all of our speakers tonight for your efforts during the pandemic and for sharing those tonight. So homai te paki for our speakers, please. I'd also like to thank the organisers, and I won't be able to name all of you, but definitely to Jerome, to Andrea. I forgot to mention at the start, sorry, but Bridie and Tamlin, who were doing the sign language interpretation. Also to Sahara, our venue manager, Alex over there, and to the AV team and the people on the door. Thank you all for making this possible. I'd also like to say the impulse to move on after the pandemic is understandable, but burying our heads in the sand is the last thing that we should do. And we've heard a very strong call to action from the stage. Shaun, you said that's why you wrote the book, and everybody has underlined the fact that, you know, there is another pandemic coming, it won't be the same, and we need to be thinking. And it's down to us, the public, to be having those conversations and to let politicians know that this is a priority and that we do need to start implementing some of these recommendations based on our successes and on our mistakes during the COVID pandemic. So I think some of the questions tonight really helped to draw out some valuable insights from our speakers. So thank you to our audience for coming tonight, for asking questions, and for the work you're about to do in spreading the word. Komo te paki. We all feel very lucky to have been here in Aotearoa during the pandemic with a government that tried to use evidence-based strategies, even when they had to make big decisions based on incomplete information. If anybody hasn't read the book already, it is very interesting and offers an insider's look on how science can be used to support decision making. I encourage you to buy it. Ina is here from University Bookshop, so you can buy a copy of this. And there's also a copy of Professor Skegg's book, The Health of the People, which was actually written before the pandemic and has a wider view, but also some very prescient and important comments to make. So I encourage you to have a look at that as well. So I'm going to close with a karakia. And after that we have about 15 minutes, so if you missed out asking your question, or if you'd like to buy a book and get it signed, please stay on. We do need to be out of here because after this there is another event from the New Zealand International Science Festival. I went last night. It's by Rachel Rayner, the science explainer, who gives a very high energy presentation on photons, so I encourage you to check that out if you don't have any plans. So for now, I will give a karakia whakamutunga to end our time together, having learned so much that we will take away with us. Ka whakairea te tapu, kia wātea ai te ara, kia tūru ki whakataha ai. Homi e, hui e, tai ki e. Thank you and good night.